Hi everyone, welcome to another episode of Retina Roundup. I'm Dr. Kavya S and I'll be taking you through this month's interesting articles. The first article is Discovisc substituted for perfluorocarbon liquid stabilizing the detached retina during vitrectomy for rhegmatogenous retinal detachment. The purpose of the study was to investigate the effectiveness of using Discovisc as an alternative to PFCL in stabilizing the detached retina during RRD surgery. 30 eyes of 30 patients with RRD underwent the Discovisc technique for stabilizing the detached retina. Following intraoperative air fluid exchange and aspiration of subretinal fluid, Discovisc was applied to seal the retinal breaks, thereby stabilizing the detached retina. Subsequent removal of the peripheral and basal vitreous was then performed. Intraoperative vitrectomy duration, retinal reattachment rate, postoperative best corrected visual acuity, intraocular pressure, and intraoperative and postoperative complications were analyzed. Coming to the results, retinal reattachment was achieved in 28 eyes, that is almost 93.3%. The base of the vitreous was removed with a mean time of 10.17 plus or minus 2.94 minutes, and the total vitrectomy time was 22.93 plus or minus 4.97 minutes. At the last follow-up, the best corrected visual acuity was 0.74 plus or minus 0.70 logMAR, showing a significant improvement over the preoperative value of 1.44 plus or minus 1.25 logMAR. On the first postoperative day, the IOP was measured at 25.71, exhibiting a statistically significant elevation compared to the preoperative IOP of 13.94 mm mercury. There was no statistical difference in IOP at the last follow-up, which was almost 14.01 millimeters of mercury compared to the preoperative IOP of 13.94 millimeters of mercury. One patient developed macular hole after the operation and there was no obvious complications during the operations. So this study concluded that Discovisc can effectively stabilize the detached retina during vitrectomy for RRD. It most significantly eliminates the risk of subfoveal PVFCL residue-related complications. Coming to the second study, it studied the impact of dexamethasone implant on slowing diabetic retinopathy progression. It was a post-hoc analysis of the MEAN study. The purpose of the study was to evaluate the effects of dexamethasone intravitreal implant treatment on diabetic retinopathy severity scores and disease progression in patients with diabetic macular edema. The 3 years randomized phase 3 MEAN study evaluated DEX 0.37 and 0.7 mg versus sham treatment at more than 6 months intervals in patients with DME. This post-hoc analysis used data from the sham and pooled DEX arms. Coming to the results of the study, the proportion of patients with more than 2-step DRSS score improvement was significantly higher after DEX treatment compared with sham at 24 months only. Among those with more than 2-step DRSS score improvement, the time to first more than 2-step improvement was shorter with DEX. There was no significant difference between the DEX and sham groups in the proportion of patients who progressed from non-proliferative to proliferative DR, but among those who progressed, the time to progression was lengthened with DEX. So this study concluded that the post-hoc analysis of MEAN study data showed that the DEX treatment may potentially have a positive impact on DR by reducing disease severity and slowing progression in DR patients with central DME. Coming to the third study, it was a study which was a novel technique of intraocular lens explantation by the knife cut technique. The purpose of the study was to report a novel technique that enables to cut any kind of foldable lens and extract it using capsulorhexis forceps and a 1.2 mm single-use slit angle knife. Coming to the method, the technique consists in using capsulorhexis forceps to maintain and stabilize the intraocular lens in the anterior chamber. And while one hand holds the IOL in that way, the second hand introduced a 1.2 mm slit angle knife through the paracentesis and cuts the IOL in 3/4 of its diameter. The IOL is then extracted in 1 or 2 pieces. Coming to the results, since March 2021, they performed this technique in 82 eyes of 79 patients. Learning curve was very fast and the technique was easily managed by 2 experimental surgeons. So this study concluded that the knife cut technique was a cheap, easy to do, and useful for all foldable IOL experimentation. Coming to the fourth study, macular buckling combined with inverted ILM membrane flap technique and air tamponade in the treatment of retinal detachment and high myopia. The purpose of the study was to assess the efficacy of integrating macular buckle with PPV, the inverted internal limiting membrane flap technique, and air tamponade in treating macular hole retinal detachment in patients with high myopia. Coming to the methods, it was a retrospective study including 62 eyes from 62 consecutive patients diagnosed with highly myopic macular hole retinal detachment. The participants were categorized into two groups, the PPV group and the combination group. BCVA, axial length progression of myopic maculopathy. BCVA, axial length, progression of myopic maculopathy, rates of macular hole closure and retinal reattachment were assessed and compared. Coming to the results, the mean follow-up duration was 14.13 plus or minus 2.57 months. The combination group demonstrated a significant higher rate of macular hole closure compared with the PPV group, 79.4% versus 100%. Retinal reattachment was successfully achieved in 100% of the eyes in the combination group after the initial surgery, in contrast to 70.59% in the PPV group. The combination group demonstrated a significantly greater improvement in BCVA compared with the PPV group. The mean myopic maculopathy stage in the PPV group increased from 2.12 to 2.38. The combination group exhibited no significant progression of myopic maculopathy postoperative. The study concluded that the integration of macular buckling with the inverted internal limiting membrane flap technique and air tamponade seems to enhance both macular closure and retinal reattachment rates, along with notable improvement in BCVA among patients with highly myopic macular hole retinal detachment. Coming to the last study, it studied the association of low serum vitamin D levels with PVR after RRD repair. The objective was to study to evaluate whether low serum vitamin D level is a risk factor for PVR after primary RRD repair. It was a retrospective multi-site case control study. The participants were subjects undergoing PPV sclerobuckle or combined PPV SD for primary RRD in the Veterans Administrative Healthcare System between January 1, 2015 and January 1, 2020. Subjects were required to have a serum 25 hydroxy vitamin D measurement within 1 year of RRD surgery and to have greater than 90 days follow-up after surgery. Coming to the methods, clinical notes and operative reports were reviewed to collect the following data, like the sex, race, age, geographic location, date of diagnosis, eye laterality, macular lens status, symptom duration, date and type of surgery, number and location of retinal tears, extent of RRD, presence of VH or choroidal detachment, date and level of vitamin D lab draw, development of PVR and need for additional surgeries. The main outcome measures were incidence of PVR following surgical RRD repair, comparing the normal and low vitamin D groups. Coming to the results, a total of 313 subjects met inclusion criteria, of whom 119 had serum vitamin D levels below the lab normal limit. Most subjects were male and Caucasians. Amongst all subjects, 42 were diagnosed with PVR after initial surgical repair. On univariate analysis, subjects with low vitamin D levels were almost 4 times more likely to develop PVR than those with normal vitamin D levels. This association of vitamin D level and PVR remains significant in multivariable analysis, and when only considering subjects with a vitamin D lab draw prior to or within 90 days of RRD diagnosis. When evaluating vitamin D levels as a continuous variable, each 1 nanogram per ml decrease in serum vitamin D below the lab specified lower limit of normal resulted in a 4% increase in the risk of PVR development. So, this study concluded that there was a significant association between low serum vitamin D levels and increased risk of PVR development after RRD repair. Future studies with more diverse patient populations are required to verify this potential association. Thank you, everyone.